Good day. You start a new series of lessons today, and we call it Obstetric Emergencies Part 1. There's also going to be a Part 2. And in this Part 1, we are going to cover breech presentations and how to manage that, delivery of a second twin in a multiple pregnancy, cord prolapse, how to manage cord prolapse, and how to manage shoulder dystocia. So in lesson 1, which you are going to do now, we are going to talk about the management of breech presentations. I hope you enjoy it and I hope you learn something new. Okay, so as I've said, we're going to, in this lesson, talk about the management of breech presentations. Now, you might think that it's unnecessary to have a whole lesson on how to manage breech presentations because you seldomly see breech presentations because it being delivered in a normal vaginal delivery, because most of them are going straight away for cesarean sections. But sometimes it might just happen that a patient has been booked for a cesarean section, a membrane's rupture. By the time she comes to the hospital, she's almost fully dilated. You can't get a hold of the doctor immediately, and then you have to be able to manage the breech presentation. And you have to be able to know at least the most important principles. Now, what is very important with these the management of these obstetric emergencies is that you don't see them often. I mean, as I've said, you seldomly see a breech presentation being born vaginally, or you seldom see a shoulder dystocia. So it's not something that because it hasn't happened often, it's not something that you can practice. So you have to know the basic principles. You should have the knowledge of the basic principles on how to manage these things. So you have to go through these slides again and again till you know it, and then you have to repeat it sometime in the future again, because we all know that there's so many things on our minds that we quickly forget what we've learned. Now we have 4 different types of breech presentations. We have a complete breech presentation, like in you see here on the diagram here, and that is where the hips and the knees are both flexed. The baby sits literally in a fetal position in the pelvis. Then we have what we call a partial breech presentation or a frank breech presentation, and here we find that the legs are in extension. The baby literally sits on his buttocks and the legs, as I'm saying, are in extension. Then this presentation here we call a foot presentation, where the foot, the hips and the knees are in extension, and we often get that when the cervix dilates, that the foot prolapse. And then in this case, we have a knee presentation where the knee is being flexed and the knee will come out first. Now, the reason why a breech delivery is a so-called emergency or an obstetric emergency is because there are some complications being associated with a breech delivery, which makes a breech delivery a emergency. The first of all is because the breech does not fit well on the cervix, because it's not as round and hard as the vertex. When the vertex presents, there are openings for, and application is not good, so there's openings where the cord can prolapse. So that's one of our big problems or possible problems, that when the membranes rupture, that the cord can prolapse. Then also, because the breech is much smaller than the vertex, the breech goes down engages into the pelvis much quicker than the vertex, and that makes that the breech presses on the rectum, and much earlier than in the case of the vertex, the patient experienced this bearing down reflex. Now, the big problem with that is that the diameter of the buttocks is much smaller than the diameter of a fetal head. So the buttocks can be born through an even not fully dilated cervix, but then when the aftercoming head comes, it might be stuck and it can't be born properly. Then there's a higher incidence of birth injuries because very often in the process of maneuvering the fetus out of the birth channel and out of the vagina, because of pressure here on the soft tissue and organs, one might very easily injure these organs and cause serious injuries. Then regarding the shoulder delivery, what might happen is what you see in this diagram is that the hands go up above the head, and as you would know, there's absolutely no way that the baby would be able to be born with his arms next to his head through a normal pelvis. So it might be that the very big baby, the shoulders are stuck like almost in a shoulder dystocia, and or that the arms get extended like you can see here, and then it's not possible to born. Or a very difficult head delivery. As I've said, usually the buttocks is small, so the legs and the buttocks and the body part of the baby is usually being born easily, but then when the shoulders and the head come, we might have problems. Now in this case, in this diagram that you see here, the head has been rotated posterior, and when we come to the management of the breech presentation, you will see that it's a very important aspect to keep the occiput of the head anterior, because when it sits here, posterior, you can see it sits here in the sacrum of the pelvis. The chin has been stuck there behind the symphysis pubis, and it's very difficult for this fetus to get born. Okay, how do we diagnose a breech presentation? Like we diagnose any presentation, we do an abdominal examination, and then we confirm it with a vaginal examination afterwards. So first of all, when we do our abdominal examination, it might be difficult to diagnose a breech presentation because especially if the mother is obese or we have very strong, tight abdominal muscles, it might be difficult to diagnose the fetal presentation here. Sometimes the head is also very high here under the maternal costal margin. So it's difficult to ballot the fetal head, to move the fetal head from side to side. And it's also difficult to feel this hard round head here in the fundal part of the uterus, which is the easy way to distinguish between a breech and a vertex presentation, because here now you feel this hard round head in the fundal part of the uterus, while you feel the soft irregular buttocks here in the pelvic part of the uterus. And as I've said, with the ballotment, with the movement of the fetal head, only the head will move, while when you ballot or move the breech, the buttocks part, the whole body will move, and that's usually how one distinguishes between the head and the buttocks part, and determine that the head is in the fundal part of the uterus. Now, sometimes the presenting part remains high, and engagement only takes place later in labor when there are contractions. And then usually another distinguishing diagnostic aspect of breech presentation is that one normally hears, remember we hear the fetal heart, usually here behind the anterior shoulder, we hear it the easiest or the loudest or the best. So you will hear the fetal heart rate where my marker is here, and it's usually above the umbilicus of the mother. That's another, as I'm saying, a distinguishing diagnostic point in a breech presentation. But sometimes, like in this case which you see here, when the breech is engaged already, this, and especially in labor, this fetal heart rate, you can see where my marker is now, it's almost on the umbilicus or just below the umbilicus. So it's not always that in the case of a breech presentation, the fetal heart will be heard above the maternal umbilicus. Now, in the case of vaginal examination, to help us further with our diagnosis, usually if we do a vaginal examination, we will feel the breech that's soft and irregular in comparison with a hard, round vertex or head. Now, often because this fetal breech part, buttocks part is very irregular and it doesn't fit very well on the cervix, we often get that the membranes bulge, and that makes it very difficult to diagnose a breech presentation, because all that you feel is one big bubble of liquor. And then when the membranes rupture, you can easily feel the soft, irregular parts. And very often, especially in labor, as the body goes through the pelvis and this buttocks part is being pressed through the pelvis, the fetus also passes meconium, and this will then be fresh meconium. This is different from fresh meconium in liquor because it's usually the fresh meconium without liquor. That one will see here. In the case of a foot or a knee presentation, one might feel the foot or the knee. And then also what makes it sometimes a little bit difficult to diagnose is that there's a lot of similarities between a breech presentation and a face presentation, because in both cases you feel irregular parts, you feel an opening, which is either the anus or the mouth, and you feel the soft cheek parts. So one can easily confuse a breech presentation with a face presentation. Now, to confirm a breech diagnosis, it obviously can be confirmed with ultrasound. And then if it has been confirmed during pregnancy, an external cephalic version can be done before 32 weeks to change the breech presentation to a cephalic presentation. And this is usually how it's been done. The baby is literally been turned after its nose to keep it in its flexed position. So with manipulation, external abdominal manipulation, the baby will be turned so that eventually his head is down in the pelvis, and we have a cephalic presentation. Now, there's a lot of debate on whether this should be done or whether it shouldn't be done. Some people feel that if a baby is in a breech presentation, there's a reason why it's in a breech presentation, and one shouldn't interfere with that. And very often when babies are being turned into a cephalic presentation, they do turn back again to a breech presentation. Now, this can only be done up to 32 weeks of pregnancy, because after 32 weeks the baby is just getting too big, and it becomes then dangerous to do an external cephalic version, because then your incidence or possible incidence of placenta abruptio and other injuries are becoming too big. So this can be done before 32 weeks and not after anymore. Now, there was for a very long time, it has been said that a cesarean section for a breech presentation is the safest. But in the meanwhile, there's a lot of evidence that has shown that vaginal deliveries of breeches can also be quite safe and without necessary side effects, negative effects, injuries, etc. But in the following cases, it's only in the following cases that the vaginal delivery can be considered. When the breech is frank or complete, if the breech is a foot presentation or a knee presentation, the patient has to go for a cesarean section, because the danger that the foot prolapses before the cervix is fully dilated is very big, and then we have all kinds of complications. As I've said, it's easier for the breech to be born through a not fully dilated cervix than for the head, after coming head. The pelvis must be adequate. That's obvious. Again, it's easier for the breech to be born through a smaller pelvis, but then the aftercoming head has to go through the same pelvis, and it might get stuck. The patient must not have had previous cesarean sections for a CPD. That's also obvious. If there was a previous CPD, the chances that in this case, there will be CPD again is then very big. The fetus must not be too large, again, because then your possibility of a CPD is too big. And as I've said now several times, the only time that you will find out that there's a possibility of a CPD is after the body of the baby has been born already. And then the healthcare worker must be competent with a vaginal breech delivery. That is very, very important, and that's why we are doing this, so that if by accident there's an emergency breech delivery, that you should be able to do it, or if the woman chooses to have a vaginal delivery and want to have a vaginal delivery, that whoever is doing the delivery should be competent in doing it. And then, as I've said, vaginal deliveries can also be safe. There is also, as I've said, evidence that vaginal deliveries can happen without injuries and possible problems. Now, when you've done your midwifery training, I think you have done lots, hopefully, about mechanisms of the labor. Now, the word mechanism of labor says how the baby moves through the pelvis during the second stage of labor. Now, in a vertex presentation or a cephalic presentation, you will remember that the head goes into the pelvis in an oblique diameter of the sagittal suture, and then this internal rotation of the head so that the head becomes in the AP diameter, then there's more flexion, etc., etc. I hope that you can still remember that. Now, also there's a mechanism of a breech delivery, how the breech moves through the pelvis. Now, I'm not going to go into too much depth and detail about the mechanism of the breech delivery. There are just some things that you need to remember. Now, as the breech comes through, as the bum part, the bottom part of the body comes through the pelvis, you will see that it follows the angle of the pelvis, and we all know that there's the angle of the pelvis goes down posterior and then it comes up anterior, and the body has to flex according to this angle of the birth channel. Then the buttocks are being born, and we will come to that just now. And then, so there are three mechanisms of labor in a breech presentation instead of just the one in the case of a vertex presentation. So we have a mechanism of how the breech moves through the pelvis. Then we have a mechanism of the shoulders, how the shoulders move through the pelvis, and the shoulders usually, like in a normal cephalic presentation, has to get in the anterior posterior diameter to be born, because otherwise this diameter is too big for the shoulders to come through. And then the head is the third part of the mechanism. The head has to be born in flexion, like you can see here, because I'm sure you can still remember with a normal vertex presentation, we've said that the more in flexion the head is, the smaller diameter presents. So the smaller diameter has to go through the pelvis, and that's why it's so important that the head should be in flexion, proper flexion. Now, to manage we are actually concentrating on the management of the second stage of labor, which is the emergency part of the labor. But in order to do that, and in order to make sure that the second stage of labor is going well, there are certain very important aspects of the management of the first stage of labor. First of all, or I would always say, in all kinds of abnormal presentations, it's a good idea to put the IV infusion on, so that if there are any problems, and these patients are also having a higher incidence of postpartum hemorrhage, then at least we have a open line already in. Then, as I've said previously, one of our big problems is cord prolapse if the membranes rupture too early. So we need to keep the membranes intact as long as possible. And this now, how we do it, all depends on the situation. As I've said, the membranes tend to bulge very early because of this abnormal position presentation, and there's lots of space for the fluid to come past the presenting part. So if the membranes bulge already, we must try and keep the patient in the bed as far as possible, because when the patient walk around and gravity further assists this movement of fluid through past the breech, then our incidence of membrane ruptures, early membrane rupture of the membranes, are becoming too big. So we have to weigh the advantage of the patient walking around with the possibility that the membranes might rupture. Then if the membranes do rupture, then we have to do a vaginal examination as quickly as possible to make sure and to exclude the possibility of a prolapse of the cord. And if there is a prolapse of the cord, that we can then react as soon as we possibly can. Now, the maternal position, obviously the mother must not be lying on her back, and the maternal position will depend on what I've said here earlier. If the membranes are not bulging, the woman can walk around, and she can also have upright kind of more sitting type of positions in bed to help for the breech to engage sooner. An empty bladder is always important in any labor, in whether it's a breech presentation or whether it's a vertex presentation, because a full bladder causes obstruction, because the full bladder sits above the symphysis pubis and makes that the head, in the case of a cephalic presentation, can't engage, and in the same in the breech presentation. But as we have said now so many times, the breech, the bum is much smaller, the diameter is much smaller. So the breech can come past where the head can't come. So the head can be, the breech can be borne past this full bladder, but when the aftercoming head comes, then there's not enough space for the head to come past. So that's very important. And then the other very important thing is, as I've said, these women often experience early bearing down reflexes, and we must prevent that with all costs, because, as I've said, the breech can come through a not fully dilated cervix, but the head can't come through. So this is very important, that we should get the cooperation of the patient. And then before we allow the patient then to bear down, she has to be fully dilated. Now, when we come to the second stage of labor, the following rules apply. As I've said, we must make sure that the cervix is fully dilated. We use the lithotomy position with the woman tilted a little bit laterally, just that she doesn't lie fully on her back. As we've said, the bladder must be empty. We regularly monitor the fetal heartbeat, and it would be a good idea to do it with a CTG if at all possible, because we are going to be busy with many things in the management of the delivery, so that we don't need to worry about the monitoring of the fetal heart as well. Now, as I've said, the cooperation of the woman is very important. She bears down during contractions, and then between contractions, we do nothing. And this, we do nothing, you will hear several times during my video here. So no traction is applied during any time, because when we pull on the breech, when there's traction, we might lead to the extension of the arms. So if we pull on the body, we might make that the arms are being extended above the fetal head. So the most important principles in the management of the second stage of labor is to allow as much as possible spontaneous birth with as little as possible interference. That is so very important, and you will see that on the little video YouTube video that I will end this series with. So that is very, very, very important. So the NB here is hands off. Do not pull. You can support the body, but don't pull. One can, when the baby's body is being born, when the buttocks have been born, one can support the baby, cover it in a towel and just hold it. But as I'm saying, never under any circumstances pull the baby. Now, in the case of a complete breech, what we do is we allow the delivery to proceed until the fetal buttocks are being visible, that we can see the fetal buttocks. And as I've said, and will several times again say, hands off. Now, as the perineum distends, one can decide whether you want to do an episiotomy or not. And one can even do an episiotomy later if necessary, when the shoulders or the head comes afterwards. I think then space might just be a little bit of a problem. So it might be a good idea to decide early whether you want to do a episiotomy or not. Then allow the legs and the buttocks to be delivered spontaneously. They come out, the mother literally pushes them out with every single contraction. And the whole body comes out until we can see the shoulder here, appearing here anterior. So you can see these hands that's doing here is just holding the baby. They under no circumstances pull the baby. And what's very important, and you will also see that on the little video, that the YouTube video, is when you do manipulate, handle, do anything on the fetus, do it here on the bony part of the fetus. Your thumbs can be here on the sacral part of the pelvis, and the fingers here on the front of the symphysis pubis part, because this is a bony part and it doesn't get as easily injured as this internal organs here. Okay, so we wait till we see the shoulder blades, and under no circumstances do we interfere. Now, in the past, for those of you who are older midwives, you've always been taught to pull down a loop of the cord to avoid traction on the umbilicus. But now, because of evidence that has shown that the more you fiddle with the cord, the bigger is the possibility that you cause spasm of the vessels. It is no longer a common practice to pull down a loop of the cord. We just let the cord stay where it is, and the body becomes born spontaneously as far as possible. In the case of a frank breech, where the legs are being extended, these legs act almost as a splint to the body, and that makes that the body comes much slower through, remember, the mechanism that I've shown you, where the body forms almost kind of a flexion through the birth channel. So we have to get the legs out. So the moment that the buttocks have been born, what we do is we put our fingers here in the popliteal area of the knee and bend the knee so that we can get the knee out. Remember in what direction the knee bends. So don't try and bend the knee the other way around. Then the delivery of the shoulders. Now we've said we wait till we see the anterior shoulder. So the moment that the anterior shoulder appears here under the symphysis pubis, all that we do is we put our finger here in above the shoulder and sweep down the anterior shoulder. Lift up the baby and do the same with the posterior shoulder. Now, what I'm saying here is ensure that the fetal back always stays anterior. Here you can see the fetal back is anterior. Remember the diagram that I've shown you of the head the occipit's been posterior and it gets stuck and the head can't be born. So the head, remember, the occipit and the back always sits on the same side. So if we keep the back anterior, it's obvious that the occipit will be anterior as well. So if the back turns posterior, we can just gently turn it anterior again so that it always stays anterior. Again, we do not pull. We still ask the mother to push with the contractions, and as I've said, we deliver then the first arm, lift up the baby, and deliver the second arm. Now the delivery of the head. Now we again allow the baby to hang, hands off. We still don't pull at all. We allow the baby to hang by its own weight, because when it hangs by its own weight, it helps with the descent and engagement of the head, and then also it helps to keep the head in flexion, which makes that the diameter that's been born is so much smaller. And then as soon as the posterior hairline appears beneath the symphysis pubis, we deliver the head. And we deliver the head by using the so-called Mauricio-Smalley-Veet method. These are three guys that developed this method, and it's been called after them. So what we do is we support the body of the baby on one hand, and I will tell you just now what this hand is doing, and then we put the other hand we have here on the back side of the baby, and we do certain things here, and then we have an assistant who's helping us here with gentle suprapubic pressure. So what this hand does is the one finger, the middle finger, goes on the chin of the baby. Now also, previously it has been said that the finger should go into the mouth of the baby, and the purpose of that was to pull the head also a little bit in flexion. Now it's also another thing that evidence has shown, that it's better not to put your finger in the mouth of the baby because the possibility of injuries. So you put your first finger and your third finger on the cheeks of the head. So you go down into the vagina, feel where you feel the mouth and the cheeks, and you do that. And with this other hand, these fingers are over the shoulders of the baby, and this middle finger pushes a little bit on the occiput part of the head to keep the head in flexion again. And then the baby has been, this part of the head has been born by lifting the baby up, and this part is coming then behind with a little bit of pulling, very little bit of pulling. Now, our biggest fear is when the arms are stretched above the head or folded around the neck, and we use the love set, so-called love set, again called after somebody who has invented the maneuver. What we do is we literally turn the baby out. We hold the baby by its hips. Remember, the hip, bony part, not the soft body part, and we turn the baby 90 degrees to keep the head uppermost, because we don't want the head to go posterior now as well. And then we get hopefully this will dislodge the posterior arm, and we can deliver the baby, and then we turn it back another 90 degrees or deliver the other arm. Now, if the head has been stuck, it's a big problem. One should kind of do a lot of suprapubic pressure, and the best way to deliver stuck head afterwards is to do a forceps delivery. That will obviously be done hopefully by a doctor. Now, here you can watch a YouTube video on this. How to do a breech delivery. It's a simulated video, but at least you can still watch it. And that brings us then to the end of this lesson on breech delivery. I hope you learned something, and I hope you will be able to do it when it's really necessary. Please complete the quiz, and then you can continue to the next lesson.